Good afternoon. This is Kelly Sheets. I'm with DMS, and I will be your host for today's meeting. I'm still admitting people through the waiting room. I have 12:59, so we've still got a minute or so to go. So Chair Poole, I don't know if you want to give it a couple of minutes, and I don't believe we currently have a quorum on as yet.
Okay, what's the number that we need? Is it 4 or 5?
We need 4.
Okay. So we have 3 of us so far, looks like.
And I am admitting Philip Almeder now, so I believe you will have a quorum. So I'm going to turn it over to you. Thank you.
Okay, all right, thank you.
Thank you.
All right, let's call the meeting to order. We've established our quorum, and then we have our minutes from our February 8th meeting. So I sent those out again to you, and does anybody have any changes to make to the minutes? And if not, do I have a motion to approve?
I give a motion to approve.
Second.
All right, Paula, and second Philip. Any further questions or discussion? All those in favor say aye,
Aye. Aye.
and any opposed? Okay. I didn't have a chance to get the updated list of people on the meeting here. Is Fatima Ali on the meeting?
I don't believe the team is, but I believe April Prather is.
Okay,
Fatima is on her way to join, though. She should be here shortly.
okay. Well, let me get 4B then out of the way. That's just contacts for Med Impact. And then we can even do 4C for now. That's the portals to look under either Med Impact or Magellan for NADAC updates. And we'll discuss those concerning new business on those a little later. But what I was, Ms. Prather, what I was wanting Fatima to comment on, and maybe you can, is the Senate Bill Savings Report that is it's been lurking out there for a very long time. And last time we talked in February, we were told it would be out by sometime at the end of March, and we're still not seeing it. And I guess the obvious question is, why hasn't it been publicized yet?
Okay, it looks like Fatima just got kicked out of the meeting, but she did want to speak to that personally, so I will defer to her when she returns. Okay, there she is.
Yeah, can everyone hear me okay?
Yes, ma'am.
Okay, excellent. Sorry about that. My computer has had some issues lately. I presume we're on Senate Bill 50 savings.
Yes, ma'am.
Okay. So, I know that pharmacy providers and really a lot of the pharmacy community has been anxiously awaiting the report. I will say that, there are a lot of pieces that go into creating the report and a lot of steps to approval, that take time to complete. So, I know that that's not the answer that you all are looking to hear, and you're all very anxiously awaiting the report, but I do ask that, you all remain patient with the department and work with us as we try to get you the best and the most accurate information as possible with regards to Senate Bill 50. As you know, Senate Bill 50 is the first of its kind in the state. So, there are a lot of things that go into it, and a lot of factors that play a huge role in, determining what the quote unquote savings are. And I refrain from using that word a little bit because of, what it could imply. And we certainly don't want to give off the wrong message, if that makes sense. So please bear with us as we finish working through the report and get it through the appropriate channels for approval.
Well, would we look at other states that have done this, like West Virginia? They were more than proud to bring it out as soon as they possibly could, what the savings were, and the legislators are keenly aware of the delay and wanting to know what the problem is. So maybe that's something that Commissioner Lee can deal with them in other meetings. Because I mean, like when West Virginia showed the savings that they did by, I mean, they had a total carve out to there wasn't any limitations at all, and the savings that they showed, they were rather proud of it. So that's the part that doesn't make sense.
I wouldn't consider our single PBM model as a carve out. A full carve out would mean that everything trickles over into fee for service. Again, we are the first in the country to have a model that is like Senate Bill 50 with a single MCO PBM. So again, I would not call it a carve out. And
Well, maybe you misunderstood me. Maybe you misunderstood me because I said West Virginia had the full carve out. And they were more than happy to show the savings on it. So I don't see where going to a single PBM or MCO for pharmacy would delay the statistics that much further. But since there was a lot of negative comments about how that this was not going to show much savings from legislators and people from Medicaid, that certainly enters your mind that, there's people that don't want this to show the savings because they were against it in the first place. So, but, the longer you wait, the more suspicious it seems.
so I think there's a distinction to make between West Virginia and Kentucky. West Virginia is a full carve out, meaning that everything goes over to fee for service. And here we're trickling everything over into a single PBM, single PDL, with a lot of other factors to take into consideration. And again, this model is pretty novel and new, and we're trying to get you the most accurate information as possible. Again, Commissioner Lee, Veronica, or Senior Deputy Commissioner Cecil are well aware of this, and they're being asked about it as well. But you need to understand that it needs to go through the proper channels before we can release it to the public.
Well, right, but I also look at how long it's been since the data has been completed. We're not continuing.
Well, I understand that, but we are looking at pharmacy claims experience over a span of 4 years, from 2018 through the end of 2022. So, compiling all of that data, again, is a lot of work, and it takes time, and it goes through multiple rounds of review and approval. And this is something that we haven't done before, so we need to be cognizant of those factors.
Right.
Do we have an anticipated release?
Unfortunately, no, because it's pretty variable right now with the amount of approval it needs to go through. And, every ounce of feedback that is given to us is incorporated into the report. But trust me, I do understand the frustration, and we are trying to expedite the processes as quickly as we can.
Anybody else have any comments on 4C or 4A? I'm sorry. Okay. And is there anybody else on the PTAC that is having pressure from their own legislators and trying to get that report? Because I've been since day one that fiscal year was over with. I've just been hit hard every time, and heck, I've even had two new legislators, and they're still asking me because of redistricting. I got a new senator, and then we had an election, and representative wants to know too, so. Anyway, as far as, we already went over 4B and 4C. 4D, as far as community health workers, the question that, we tried to bring up as pharmacy owners are going to qualify as providers, or excuse me, pharmacies are qualified as Medicaid providers. So it looks like the verbiage where I can pull up on my phone here. Let me do it that way. Basically, the people who are eligible to have community health workers, another Medicaid participating provider approved by the Department of Medicaid Services. Obviously, in other states, this has been spelled out where pharmacies and pharmacists and staff working under pharmacists have been able to go ahead and move forward with these things. The thing that most pharmacists understand is that we've already been doing a lot of these programs for some time and getting paid nothing for them, but trying to do what's best for the patient. And the sad part is a lot of these programs cost money, and therefore the only people who can afford some of the help that a community health worker would be eligible to do, they have to pay cash for it. And so basically right now, a lot of these services that community health workers can do are being paid for, but as far as trying to get health equity going in this state, a big move would be to open it up, open the community health worker waiver up to put pharmacists and pharmacy technician staff, because those of you who don't work in a pharmacy, these things happen all the time. We could go on and on for days. I mean, especially those of us who have been pharmacy owners for years and years, all the things that we've done to assist people in getting their medications, getting to and from office visits, or any kind of deficit that they have in attaining health care. We've been working with them for quite some time. Ben Mudd, are you on the phone? Are you on the call today?
Yeah, I'm here, Ron.
Would you mind to comment on your thoughts on this?
Well, I think, KPHA definitely supports the ability for pharmacies to be listed as providers here, with pharmacists and technicians being the one that obviously be providing the service. I'm still a little confused on the why not of why this can't happen. Is it an interpretation of the statute? Is it just I don't know how to say this. Is it just Medicaid doesn't feel like this is an appropriate thing for pharmacies to be doing, or that's not the right place for this to occur? So I guess some clarification on the why not would be a good place to start.
Yeah. And just
So-
so you know, Fatima, in other states, I've got colleagues in other states that have 12 community health workers on their staff, and they're doing all the support for these people to attain health care, and all the ones with barriers, and they're getting paid for it through their Medicaid program. So it's being done already in other states. So anyway, go ahead.
Sure. So I'll be honest that, this is, something that I'm not fully in charge of. I can certainly have discussions with those who are in charge of this waiver within the department. But what I would need from this group is, the estimated costs that, could come our way, and what this would look like. Just a written proposal would really be helpful here for us to consider something like this.
did the other people that were approved on this list, did they have to come up with an estimation of cost to provide care under community health workers?
That's something I'm unsure of, but again, I was not, this is not something that I've been taking the lead on. I think we might need to have a comprehensive discussion with the individuals who did make those decisions and see where we can go from there.
Well, would you mind to provide me and everybody else, or at least Aaron or Kelly, the contact people, so we could address the appropriate people, and because we're trying to figure out why we're always left out. That's the main thing.
Yeah, I'll correspond with Aaron and Kelly and we'll see where we can go from there, but I would highly encourage a written proposal from this group.
Yeah, Ron, I agree. I'd love to know if the other people, I pulled up the provider letter that went out from the cabinet on community health workers and all the entities that were addressed, physicians, school-based services, community health centers, dental providers. I'm not really sure why pharmacy wouldn't be the obvious choice to be included on this list. And I'm like you, I would like to know if what we're being asked to do, it was done by all these other people listed on this list. And I'd love to be in contact with the right people that can help answer some of those questions, because I think it's a valuable service and, in the long run does save money. And I think pharmacy is, as the accessible providers that we are in line to provide those services.
Fatima, this is Angie Parker. I'm the Director of Quality and Population Health, and I've been involved in some of the CHW discussions. Now, our health policy division, healthcare policy division, is the one who's been developing these. As you all know, this is a new process that just started July 1st. So we are looking at any input from any other providers to this subject and any changes that we could potentially make. So as what Fatima Dr. Ali had mentioned, it would be good to have that information from you on how you would like to add pharmacy to this, and we can certainly send this to the correct division to do some investigation. It's we are making changes as we go, as we get additional information, so it's very helpful. I don't think it was meant to be I can't think of the right word, to eliminate you all from this process, but there's some questions that I can't answer as far as, are you able to build those specific codes that are currently listed would be accepted for CHW? Do you currently employ CHWs? Are you looking to certify them? Because there are a lot of requirements for this. So if that is something that pharmacies are doing elsewhere and in other states, please send as Dr. Ali stated, what your proposal is, and it can certainly be reviewed.
We'll be more than glad to do that, because we already have examples being done, and seems like a lot of states, the community health workers were thought of as working under the pharmacy, since we're the most accessible healthcare out there. So a lot of states didn't forget the most accessible profession out there, and we already have people that do a lot of these programs, or these that just any barrier to care that we work with the patient to help them attain whatever health care they need. So I think it's we'll be more than glad to make comments, because I understand they're working on the regulations as we speak. So
Yes,
pertaining to this statute. So we'll be more than glad to. And thank you, Ms. Parker, for your comments.
that would be very helpful. Thank you very much.
Okay. Okay, on
Hey,
new business.
Rod,
Yes, go ahead.
question for Ms. Parker is, would the most appropriate way to to handle that be through official comments on the regulation, or what's the most appropriate way to get that?
You could do
request?
both.
Okay.
You know, you're bringing it up in the TAC, and this is concern, and you can certainly provide what you would like to see DMS to do, and you can do it, provide your comments on the regulation comments as well.
Okay.
Okay.
We are working through this, as I said, this became effective July 1st, so we want to make sure that we are including, because we have the same concerns regarding access to care and ensuring that we look to see the CHWs to fill a hole that's not been there.
I think, and there are some examples in Kentucky and beyond, but you know, it's, if patients don't have electricity or food to eat, then that's probably becomes #1 priority over taking care of a diabetic foot ulcer. They don't have clean water, how they're supposed to clean that, take care of it. We need, you know, and pharmacies see that because they deliver to their homes and they see what they're going through. So it's a great opportunity for an intervention. But not everybody realizes, you know, or recognizes that pharmacy has that opportunity. So look forward to the opportunity to present those comments.
We're more than welcome to see what you have to information that you have. Appreciate it.
Thanks.
Yeah, we've delivered to patients' homes before where they have dirt floors for floors. So, okay. On moving on to new patient or new business, I put that in there because it's already been taken care of and addressed. But we had a situation in Central City where a physician group that takes care of addiction medicine was prescribing stimulants for for a condition that is not approved by either the DEA or even by MSDS, the disease state management book. So anyway, that got resolved because when they understood that's the reason why somebody was denied a stimulant drug when we had so many of them being prescribed for meth addiction, which I believe in the next few years I mean, that'll be some semblance of that will be the standard, but as of right now, it is not. So that's what happened in that case, and it's been, I think, Dr. Schuster's had the conversation with a colleague of mine to explain that, but it wasn't somebody denying somebody a legitimate prescription for a legitimate disease. So looking at just to report a little bit more on the brand name and generic shortages, we still, it's amazing to me. You know, we thought that this is what we were going to endure during the pandemic. And I realize we still, you know, have an uptick of positive COVID cases right now, but so a lot of people like to think we're out of the pandemic, but whatever your particular take on that is fine with me. But now we're starting to see, you know, shortages on generics that are not, you know, it shouldn't be that way. So we have, you know, a lot of brand names certainly, and generics that we normally don't see a problem with hydroxyzine and lidocaine viscous and hydroxyzine syrup. So I just want to bring that to your attention that we're getting inundated with people that are having issues obtaining medicine. They're wanting to report us to the Board of Pharmacy. They're wanting to report us to whoever they can talk to because we just can't simply get the medicine. And we have gone through every means possible. I am now, when I look for all of my pharmacies, I've now have over 105 secondary wholesalers that I can check. There's 4 or 5 different entities that represent 30 and 25 secondaries. So it's not like I'm doing 105 different websites. It does amount to about 15. But anyway, it's still amazing. You go through all of them and you can't find the product. And it's not like it used to be 10, 15 years ago. You have such strict requirements to order, and a lot of these drugs are your C2 drugs. And you have such strict criteria to meet in trying to order anything else beside from your primary wholesaler on C2s, that I only have 2 other ones that I can even try to order from. And then I still have to jump through their hoops to get it ordered. So if I order a bottle of 100 of anything, then I have to order 300 of a non-controlled from this entity to get it. Or I have to have a dollar amount that I average over the last 3 months that I've ordered from them in order to order a C2. So there are secondaries out there with these products, but if you haven't ordered anything from them in 2 months, then you're out of luck. And so it's the worst I've ever seen in my almost 33 years in trying to just obtain drugs every day. I mean, I have my staff email me all the list of drugs that they don't have, and it just continues to build, seems like every day. So it's a constant that every pharmacy is having a problem with right now. And I don't remember a worse time. I can maybe remember a time when digoxin was being shorted. And of course, there's not an alternative to it. But that's the only thing I can liken to the situation we're in now. I don't know if anybody else had any comments on just the supply chain problems.
From a Medicaid perspective, I will say that, we are aware of these shortages and we're trying to work with pharmacies as best as possible to, if the brand is preferred, allow the generic to pay and vice versa, in warranted situations. So, as these issues come up, certainly bring them to us and we can work with you. We certainly understand it's a big problem, unfortunately out of our control. But, if there is something that you see, please let us know.
Okay. And I just wanted to present this to the Medicaid department. This is just Pools Pharmacy Care. Because we're not able to meet our generic compliance rate because of the brand name preference is part of it. It's not all of it. The other is such a high demand for GLP-1 drugs that adds to that. But basically, just by not being able to meet those measurements annually, it's going to be somewhere projected between $30,000 and $42,000 annually that it's costing. So Medicaid may be benefiting from the brand names for the rebate program, but it does have a cost to your providers. And I have just looked at our particular buying group, and before we started having the preferred brand names on Medicaid program, we were at an 80% clip of being able to meet those, what they call GCRs, generic compliance rate. And now we're at 42% of people can meet their GCRs. So it does have a financial impact, and here we're trying our best to take care of Medicaid patients. But, others may choose to just say, well, we don't have that medication or whatever. But that's where people are looking at is what financial impact is this having? And, what's their means to deal with it. And some are choosing to just saying we don't have it. So just want to bring that to your attention. And I don't know if anybody else has done the evaluation of what that costs them, but anyway.
Ron, I can say from our company, Jordan Drug, our estimate is about the same, maybe a little bit higher. We have 6 stores. And from hearing from my KIPA members across the state, there is, it's been a huge impact on losing our rebates for GCR. So it is definitely an issue across the state.
Okay, moving on. Go
I
ahead.
just want to comment and add that the availability right now of the GLP-1s is anybody on here who works in a pharmacy knows it's just driving everybody crazy. The patients get emotional, very emotional at the counter. If you have it, they get emotional if you don't have it. And I do appreciate the board coming out against some of the practices, but I think I've never seen, and I've not been a pharmacist as long as some of you have been pharmacists, obviously, but I've never seen so much hype over FDA approved on-label, off-label indications in my career ever. So it's definitely having an impact on the profession.
Yeah, I appreciate those comments. That's for sure. In the last, I've just started I wrote a lot on this next topic here. Answers from Mrs. Latkins Alvarez and Mr. Boglass, if I'm pronouncing his name right. But I just started the conversation with them, and we used to have an ad hoc committee for Medicaid and compounding formulary, and UK Med Center really weighed in a lot with that. And I was able to just come up with just some simple things that would really help them out in patient care, because a lot of times they're compounding because it's just that much better for the patient. And of course, they're not getting reimbursed for that. And I've just started the conversation, and it whether it's compounding, whether it's nutritional supplements that are needed for autistic patients or ADD or ADHD. So many times patients are getting referred from their physicians, and obviously from myself. And the nutrition they need, they can't afford it as far as nutritional supplements. With autism, glutathione and essential fatty acids, and all those do add up as far as expense, whether it's taurine or zinc or any of those. So in looking at all 4 of those topics there, I've just started to other states, we're all trying to work with not only Medicaid, but all third-party payers on pharmacist clinical services. We're all, looking at these kind of, because this is right now is the change. State of Washington was the first ones 8 or 9 years ago to get legislation changed, and they're still working on their not only private but Medicaid population to try to see where they can help improve quality of care and save money, which is the main thing for most third parties and Medicaid too. The only thing that I would ask, if we have a representative on here from MedImpact, is there any possible way for when there's NADAC pricing updates, which I understand tend to be 2 to 3 weeks retroactive, is there any possible way to have it to be automated, to where when you have submitted a claim that should have been with the new NADAC, and 2 weeks later it is updated and it is retroactive back to that claim? Just wanted to get that question out there, and if nobody's on here, then I'll follow up with the MedImpact administration.
Yeah, so MedImpact is on, but I will say that in terms of those NADAC rates that, are retroactive, or, the claims that are submitted and then the NADAC comes out and then you have to retroactively go back. So that would be incumbent on the pharmacy to reverse and reprocess those claims accordingly. And again, NADAC is managed by CMS under their vendor Myers and Stauffer. And I think you all have NADAC appeal information. If not, I can throw it in the chat. So, it would have to really go through that process where when the rate is updated, the pharmacy goes back and reverses and resubmits the claim.
All right, and why is that?
In terms of,
Because MedImpact's got the capability to identify those claims. And if you've ever opened up one of those portals to see the voluminous amount of material that you got to go through to find your NDC number, and then to try to determine, which claims to do it on, is that the cost savings measures of the retroactive NADAC pricing updates that they get to pocket? Because it seems like to me, if you filled a claim under when a NADAC price should have been updated to begin with, looks like that should have been your reimbursement period. So to have to go through, you're talking about, procedures with Medicaid about how this is different. Well, being they can identify those claims overnight. I'll bet you there's a report out there that shows how many of those NADAC prices didn't get updated under Medicaid or under MedImpact. So to me, it's a way of a cash flow measure for them to not have to pay the NADAC price when it should have been effective to begin with. And they have
knowledge and MedImpact, feel free to jump in here. I don't think that this process is really industry standard, and I don't think it happens across the board.
because most insurances can update on a very quick basis
So
on
if
their
our commercial-
pricing.
Are commercial PBMs helping you all reverse and reprocess claims in that fashion?
Yeah, there's some that will go ahead and reprocess, and there's some that will just send you a report that tells you these are the drugs that you have filled that you can go back and rebill. They don't just send I don't know if y'all paid attention to how many pages worth of information is in one particular report, but last time I checked, it was 30 some pages worth of NDC numbers to try to have to find a needle in a haystack of what claims you have to, unless you have a Microsoft Access acumen to where you can take a database and do a search and find the claims.
So how frequently are these commercial PBMs sending reports to you all? Is it monthly, quarterly, weekly?
It's monthly through most of our pharmacy administrative organizations. And we can even, we can do reports off of some of them that'll just tell us which ones to go and rebill. And then sometimes they'll just send you an email with an update of claims you need to be looking at to see if you got the proper reimbursement.
Okay.
So I'm sorry, you said your PSAOs are sending it to you because they want those adjusted. Is that what I'm getting?
They provide those for us, and in some
So it's
cases,
not the PBM, it's the PSAO who gets a little piece of the management to those and the reprocessing. So
well, they wouldn't know the claim unless the PBM was provided for them.
well, right, but a lot of the providers have a PSAO receive their RAs and their 835, so they're going through them and identifying them that way. So, identifying the claims, to your point, is one thing, but if we were to send you a list of those to process or reprocess, we would pull both, right? So it would be increases and decreases, and we would expect that all the increases and the decreases were both reprocessed in that situation as well. Is that what you're also committing to? If we were to send a report like that?
Well, if we could send a
We have
report,
to
like
develop
that,
it. Yeah.
But right now, it's one-sided. What's the percentage of people do you think that are out there reprocessing? Very low.
Well, but again, in Medicaid programs, this is not a standard process to go back and have an automated piece. So for us going in and doing an automated readjustment, that would be akin to rebilling and reprocessing. We'd have to check with our compliance and legal and see if that's even a viable option from that perspective. I don't know if they would agree with
But you
it.
have certain Medicaid programs that use other pricing models that don't have to wait 2 to 3 weeks for a
Well,
retro.
What was it?
update.
48 states are based on NADAC now. There are only
Okay.
2 left that aren't. So most of them are using NADAC. So they do have the same limitations from the CMS process, right? So again, think about it from when a manufacturer makes a change or provides an update to a wholesaler around AWP or WAC. You do probably get those in your price file, and we do get those daily when they come over from that perspective. But it's the Myers and Stauffer and the CMS process there that creates this situation where we do have that unfortunate inherent delay in their validation, verification, and then ultimately the publication of those items. So I think, again, it goes to both sides, right? Because there are increases and decreases when you see these. I know obviously the concern here from your perspective are the increases by and large, but there are probably times when you've achieved that lower price because again, or the price changes in there, or you have inventory on the shelf that was at a lower price from that perspective. So, again, we'd have to take it back to Dr. Ali and see what we could provide from a reporting perspective. And then of course, I think that would probably be something that we'd have to discuss there. And then we'd have to, send it out and watch and make sure that all claims are being reprocessed from your side. Yeah. But we can talk about it, certainly. I mean, we're open to listen and help you guys how we can from those perspectives. We just have to remember, obviously, that we're just the benefit administrator for the state. So all of the decisions would have to come from the Commonwealth, and then we would be able to support whatever they decide from that perspective. Yeah. So we're not traditional PBM like you had with the MCO, as we're more of an administrator from that perspective. So we'd obviously listen, take back what we can, and then work with Dr. Ali and Dr. Prather and Dr. Van Gilder.
But I'm sure you're all aware of how you're all benefiting from pharmacies not having the time and wherewithal to take a massive report and find those particular NDCs that they can go back and rebuild, because I have not found a colleague out there anywhere that is doing that.
Well, but we're not benefiting from that in any way. This is.
How are you not? I mean, you got a price that should have been updated 2 and 3 weeks ago, but because the process, it wasn't, so you're paying at a lower rate. So you are benefiting from that. And it's not getting reimbursed.
Right, but it's not our network, it's the state's network. So there's nothing that we receive on this. We're paid per member enrolled in the program from this perspective. We're not paid based upon anything related to the claim transaction.
Okay. So, but Medicaid is benefiting off the NADAC 2 and 3 week delay. But anyway.
Well, I think another point to note is that, the price could increase or decrease with those batch reversals, if you will. It could go favorably or unfavorably for the pharmacy from that end. And again, we have no control over what CMS does with their NADAC and the methodology there. I do have a NADAC document if you'd like me to share that with the methodology.
No, I've seen that before, and we've tried to make that available for all the pharmacies out there, whether chain or independent, of how the process goes. But it's been, I've been in this business for going on 33 years, and I sure have never seen too many price decreases. As far as most of the time, you're talking about price increases. So by that not being updated, that is a benefit. Anyway, moving on to, let's see, 5E. We're having some people that are billing for the vaccine consultation. And what are they supposed to do with the denied claims? Because by Medicare mandate, we're supposed to get those paid for. So where is a resource, or where can they go to report the denied claims?
So you're referring to vaccine counseling reimbursement?
Yes, ma'am.
Yeah, so, those are funneled through the MCOs because it is billed on the medical side. And we did share some useful billing information with Benjamin. So, I think referring to that information is certainly helpful for pharmacies. For any denials, you would go through the appropriate MCO and work with them, and we're happy to triage some of those for you. Well, not some of those, but really any concerns that you have from that perspective. And then we'll also be discussing it in the Med Impact Provider Forum, which will be later this month.
Okay. Ben, did you get that helpful information?
Yeah, it's available on KPHA's website too. And there's a pending communication going out to all members as well.
Okay. And then who's getting this information? Are we sending that stuff out to the chains also, Ben?
Um,
Or you're just making it available on the website?
it's not just on our website, but they'll be going over it in the next Med Impact Provider call as well.
Okay. All right. Thanks. Have you had anybody yet, Ben, or is it just too new to, that the information just now been available, or have people been successful in calling and getting them rebuilt?
I mean, I know of a couple folks that have received paid claims, so
Okay.
it's real. It's just had, I think having pharmacies transition to that payment model through medical billing is, it's a hoop we got to jump through, but
Yeah.
it's helpful, when you have, it just takes a few people to show success and getting that message out there. But at this point, even if you're providing a vaccine consultation and patients aren't getting a vaccine because of safety concerns, you should absolutely be billing the MCO for that consultation. And we have it on the website. We got sample documentation for what a note might look like for that encounter, the codes, the CPT code, and the diagnosis code that you would need to bill it. So not super complicated, but it is a little bit different. So.
Okay. All right. Thank you, sir. Put 5F on here. I would like to star it and put it even in its own entity, but I want to thank Dr. Lee and Dr. Ali and Commissioner Lee for all the work they did on getting the increased vaccination fee for reimbursements. I know that was a lot of conversation, a long time coming, but we certainly appreciate your efforts on that.
Sure. Thank you.
And I didn't have anything under general discussion or recommendations. The next MAC meeting will be September 28th at 10 a.m. As far as I know, I'll be able to present that morning, just our discussion that we had today. I want to just continue on and just laying the groundwork for some discussions and possibly talking to the Med Impact people on possibly even have committees or whatever to discuss some of these issues on just your non-traditional pharmacy claims. So anyway, I'm going to be working on that. If I obviously we get anything going, it'll have to be approved by the TAC. So I'll let you know on that. And our next meeting that we have scheduled is on October 25th. It'll be Wednesday at 1 p.m. Eastern. Did anybody else have anything under general discussion or anything else today?
Rod, I'd just like to say, I want to thank you today for, whether we were talking about trying to manage the NADAC prices and monitoring those changes and resubmitting, or, how we're trying to track down drugs and because of the shortages, or managing the compliance ratios when we're trying to balance these high dollar drugs that we're being forced to use when there's generics available. I think you've done a really good job about highlighting the extra time, effort, and cost that goes into, providing care to Medicaid patients, and how, the added effort that we take just to make sure that there is the availability and access to care that they need. So thank you for that.
Well, you're welcome. And thank you for your kind comments. Okay. Anything else? If not, have a motion to adjourn.
Motion to adjourn.
Second,
Motion by Meredith, second by Rosemary. Is that correct?
right, correct.
Okay. All those in favor say aye.
Aye.
Any opposed? Thank you all. Appreciate your time.
Thank you, everyone.
Thank you.
Thanks. Bye.